just thought, I'll put some fun behind because I'm sitting in a drab office right now.
No, absolutely, absolutely.
I hope it's okay, but
I think it's refreshing. Oh, very cool.
Okay. Good afternoon, everyone. I am Harsiddhi Shah, Senior Associate Programs at AICGUSEC, that is Atal Incubation Center at the Gujarat University. AICGUSEC is a non-for-profit company that aspires to become a change agent by identifying, nurturing, and supporting ideas with impact. For this, we offer a collaborative no-cost incubation program to for-profit social entrepreneurs, enterprises, and act as a bridge between the solution and problems to the society. I welcome you all to the webinar, Importance of Big Data in Healthcare. I am pleased to inform that AICGUSEC and TIDE Delhi have organized this webinar with the support of Atal Innovation Mission, Niti Aayog, and Gujarat University. This webinar is meant to create an awareness about changes and innovations in healthcare sector and also help the healthcare entrepreneurs in their growth journey. With that objective, I am very happy to inform all of you about the Aarogyam Challenge, which is ongoing, the Aarogyam Challenge 2021. It is for all the ideators, innovators, and entrepreneurs from the healthcare domain. This again is an initiative by TIDE Delhi and AICGUSEC. The last date to apply for this challenge is 13th November 2021. We request everyone who is interested and eligible for this to please visit our website aicgusec.org/Aarogyam, AAROGYAM, for more information on the same. Let's get back to today's topic, which is importance of big data in healthcare. One of the most notable areas where data analytics is making significant changes is healthcare. Various sources for big data include hospital records, medical records of patients, results of medical examinations, and devices that are part of the Internet of Things today. In today's webinar, we have expert panelists who will be discussing and will address the need for big data in healthcare and hospitals. That is, why and how it can help, what are the obstacles to its adoption, where are we with its use, and where can we reach? What is the potential in front of us? So without any further ado, I would like to start the panel discussion, and I would like to introduce our panel moderator for today. That is again Rahul Gupta, venture capitalist, Times Internet. Rahul looks at early stage investments for Times Internet, where they have backed companies like Clinic Healthcare, Myra Medicines, and more. He's also an angel investor and has backed healthcare companies like Spira Healthcare and Zoconut. During the pandemic, he co-founded Project Step One, which is India's largest effort in the fight against COVID that assisted over 4 million COVID positive patients. We are happy to have you here, Rahul, and over to you. Welcome all the panelists and have a great one. Thank you. Over to you, Rahul.
Thank you so very much. Great to be here. I have an esteemed panel where they're not only esteemed entrepreneurs, but hats off to whatever they're doing, because it has an insane amount of impact in what they solve every day. Thank you so very much. I have Anu Acharya, the founder of Map My Genome, Geeta, who's the co-founder of, I'm so sorry. Hello? Hello?
You're audible. You're audible.
Hello?
We can hear you.
Yeah, we can hear you.
Yeah, hi. Am I audible?
yes.
Hey, I'm so sorry. Yes, I have Geeta, who's the co-founder of, I am really sorry.
Niramai.
Niramai, I'm really, really sorry. And Dr. Shuchin Bajaj, who founded Cygnus Hospitals. Geeta, I actually want to start with you. What is big data, first of all?
Hi, great to be part of this panel and esteemed panelists, and thanks to the organizers for inviting. Yeah, so just to sort of recap, I'm founder of Niramai Health Analytics, where we've developed a new method of detecting breast cancer. I think when you hear the word big data, one of the main things that people perceive is big, that is volume, right? But technically speaking, big data has multiple connotations. It usually is defined with respect to multiple V's. One V being volume, which is the size of the data itself. Another V being variety, that is, there is different types of data that's coming in, could be image, video, text, numbers, and like things like that. So there are different data types of data that's coming in. And so it becomes like pretty complex to crunch that kind of data. A third V is velocity, like, things that are changing over time, right? If you, let's say, next to ICU bed, right? You know that there's this BP reading, probably the heart rate, and it's coming like continuously. And that's important to look at this velocity or running data, right? Data that is changing, or like the weather also is changing, but it's changing at a different rate. And for healthcare, when we talk about monitoring, we definitely are talking about, or like variables, right? Every step and every, like it's like sensing on a real-time basis, right? So that's the velocity of the data. And next we talk about veracity of data. Veracity of data typically actually means that this is data which is either missing or corrupted, or it's actually real data, not cleaned up data. It's about real data coming in from the ground. So there could be errors. There could be, like, for example, you're monitoring a patient and suddenly like all good ECG rate goes to 0. Usually assume like there's no activity, but it's also possible that the wire which is connected to that device it came out, right? So basically trying to handle these real-time challenges of having a valid, cleaned up, verified data is also another challenge. So that, and people have been trying to add more V's to it, valuable and all of the other V's, but generally, like, what technologists generally consider big data as at least having one of these 4 V's, right? Even if the data is so huge that, we're talking about terabytes of data, and we're going to talk about healthcare data, how huge it is, and particularly Anu is going to talk about genomics, right? Where there's really, really huge amount of data. Volume itself is a big problem. Again, each of the V's that I talked about, you can think about how each one of them can be a big problem. So whenever there is a startup, there is a technology, there is a solution which is solving at least one of these V's, it's already solving a big data problem.
Very cool. Geeta, just want to, again, start with you and then go to Anu and Dr. Shuchin, right? Which V do you work with, or do you work with all 4 of these V's? Yeah, it's very good. So once you have this data, what you do with it is also very, very important, right? Like whether you just sort of look at, analyzing it and then give the out, or you're going to predict something new, and so on and so forth. In our case, we work with both heterogeneous data as well as volume. That is, variety and volume is the main thing that we work with, and also veracity, like any real-time deployed solution. So just to go into more details, as I mentioned, at Niramai, we have developed a new method of detecting breast cancer. We have used a different type of sensing called thermal sensing. Thermal sensing is something that everyone is aware of. Thanks to COVID, like, each one of us would have gone through a thermal scanner with that infrared thermometer like 100 times now or more. So we use a similar thermal imaging device, but measures the temperature variations on the chest, like multiple, like high resolution. So it actually measures 4 lakh data points per person. And how do we make sense of this, right? How do we make sense of this sort of huge amounts of temperature data that's coming from the body? So that is the AI-based model that we have developed to say at real time whether the person in front of us is likely to have breast cancer. Breast cancer is actually the largest cancer killer in women.
In India alone, about 90,000 women died last year. So it's a very, very important problem. And there are lots of gaps in the solution. So we have used thermal sensor, measuring huge amounts of data from the person, and then figuring it out to say whether the person has cancer, where is the cancer, and what is the likelihood, and what kind of sort of follow-up that is needed. So that is what we have developed. And doing it in places like villages and at home, and of course in hospitals and so on, gives us this methodology required to ensure that the data is clean, the data is correct. Right? So we can talk more about how do we ensure that the data that's coming in is good enough for crunching, but that's so veracity, volume, and variety is something that we have.
Very cool. Thank you so much. Over to you, Anu. Would be amazing if you could give us a 30-second explainer of what you're solving at MapMyGenome, and also, what is your understanding and how are you using some of these ways? You're on mute.
Thanks, Rahul. I was thinking of all the V's, and then the one V I was thinking of is not something that you use in big data, but anyway, we'll leave that. So what we're trying to do at MapMyGenome is essentially help people know themselves better by looking at their DNA and basically helping them to analyze it. Now, while it might sound fairly simple saying that you look at a particular somebody's DNA and understand it, I think what the real value comes from the fact that one, you're looking at large volumes of data for each individual. So each of your cells has a lot of DNA, and the DNA has about 3.2 billion base pairs, so 6.4 billion base pairs. So it's like a large amount of data for each individual that you're collecting. And in order to make sense of that, you have to basically compare it against hundreds and thousands of other such individuals with a similar sort of background. So I think the value of big data in genomics is obvious because of just this sheer size, but also the fact that most of this data is in the form of A, C, T's, and G's. And therefore, I think helping that understand is what we do. But you can do a lot of things with it ultimately from an application point of view. So for instance, you can help understand the risk of disease. You can understand if a drug will work for you. You can understand if where you come from because your DNA holds traces of that. And you can also understand if certain nutrition is going to work for you and so on. So it can be helpful in a variety of different ways. And the way it has come about is because you have been looking at large amounts of data across the planet and therefore have been able to come up with these kind of observations.
Very cool. Very cool. Dr. Shuchi, would love to understand, how do you look at using this big data for a hospital in particular?
Yeah, thanks, Rahul. Really happy to be here. We run a group of hospitals in small towns of North India. Unfortunately, Indian healthcare, as has been pointed out repeatedly, I think we are very good on execution, but not so good on data management, data analytics, putting out research papers, and just analyzing the huge amount of data that we have. So, as very rightly pointed out, it's not about the data, but it's about how you use and store the data that is really of importance, right? We do create millions and millions of data points almost every month, but due to the limitations that we have on data analytics and data storage, we don't really rely on data that is produced out of India. So we just rely that any drug that was effective on a 6 feet Caucasian living on the east coast of the United States having a meat-based diet, if that drug was effective on that person, so it will definitely be also effective on a 5'4" person living on the east coast of India having a completely rice-based diet. This is what we are doing right now. So we think that using the data that we generate and analyzing and putting out there will effectively reduce the cost of disease by a huge margin, because we will have so much of preventive and primary knowledge about the disease, and this is exactly what Israel has been doing, and we have the opportunity to leapfrog it by at least 20 years with the Ayushman Bharat scheme and the PMJ scheme coming in with their huge emphasis on digital records and digital complete, the formulary, the drug formulary, and the digital disease record keeping. So, if you understand that if a person has developed diabetes today, and he has those five characteristics that will lead to kidney failure in the next 20 years, versus a person who's developed diabetes today and has none of those five characteristics, instead of expending your effort, time, and everything on both the patients equally, you would rather concentrate on the person who's likely to end up in kidney failure and make sure that he is the one that has better control of diabetes. He's the one that's followed up more regularly, because he is the one that will require dialysis 2 times a week 20 years from now, and not the other one. So if we can identify these data points early on, if we can make sure that we work on them and clearly know what exactly each and every patient is going through, that will be the appropriate use of the huge humongous amounts of data that we are generating on a day-to-day basis in the Indian healthcare scenario.
Very, very, very interesting thoughts. And I'm, what Anu said and what you said also was a lot in sync, essentially. Anu, just wanted to understand how do you essentially, what are some core factors, right? Like Dr. Bajaj said, like, hey, somebody living on the West Coast in the US and somebody living in the East, on the Eastern Coast in India, right? So because of so many different factors, right, the same things will not be valid, right? What are some 5 or 10, or essentially what are key factors that you look at, with respect to, for example, predictive healthcare, right? That these are essential pillars that define that X may not be relevant for patient A and B.
So there are several factors, and I'll give some few examples. So I think in a lot of hospitals, for instance, they know that people from a certain caste might not react well to a warfarin drug or certain kinds of drugs, right? And that is actually happening because of a mutation that happens in those specific tribes or a certain sect of people. Some of it can be explained through genetics. So you can say that, because of this change or a mutation, we can actually understand why a certain drug will work for somebody, why a certain drug will not work for somebody else, because you can basically look at the downstream and say, this is what happens to the protein, this is what happens to the enzyme, and blah. So you can explain that through the genetic piece. The second part is that, and I think Dr. Bajaj also mentioned, was when you look at also just regular blood parameters also, right? We have certain things like, when you look at blood pressure, you look at calcium score, you look at certain things. A lot of medicine was basically done because your standards or the base level of data that you took was that of a Caucasian male. And that sort of creates a problem, because I think it's not the same. Vitamin D levels in certain population doesn't mean the same as it means in the Indian population, for instance. So there's a need to say, how do we create our own baseline and be able to get through with that? So there is the genetics piece. So to understand whether drugs will work or whether your risk for certain diseases, or all of that cannot be explained through just mutations or otherwise. The second is to say, can we look at blood parameters and explain it or normalize it for different populations? And if not, let's say, let's not normalize, but you have all the data points. And the third is how we live and what we eat. Because how we live in terms of how we exercise, how we spend our regular, normal day, how we would actually, sleep, how do you do all of that? So if you look at the whole lifestyle for an individual, that also influences very substantially on how your health risk is predicted. So what we're doing, for instance, is putting all these pieces together and saying, you not only do the genomics, but you do all of the other factors, and then you run it through a machine learning algorithm, because that will give you the best outcome over there. So that's part of what we are trying to do. So, and this is not, of course, not the end all of it, but you can basically look at it in 3 big buckets. The way at least we look at it is lifestyle, your current conditions, which can be understood by biomarkers of different kinds, and the third is your inherent conditions, which is your genetics. Genetics, the germline changes very little, but your somatic might change. you can look at that if you're looking at specific kinds of conditions. But if you're looking at just understanding of health, then I would put it under these three big buckets, but each of these buckets have smaller amounts of data that go along with it.
Very interesting. Geeta, just to go back on what you are doing, usually all startups come and ask one question: hey, how do we start training the data, but where do we get this data from, right? So usually that's the most common problem. So how I wanted to understand how both of you started, Anu and Geeta, essentially, where did you get that data from?
Sure. I think it's a very good question because there are different problems that we can look at, and different problems have different ways of getting to the data, right? Especially assuming that this is a data-based solution we have. In our case, when we said we want to solve this problem of breast cancer, and you asked this question, what is the gap today? The most common method of detecting breast cancer, even like so far at least, was mammography, which was X-ray of the breast. And that itself had a limitation that X-rays are not able to capture any signatures that are abnormal in women with dense breasts, which basically is every lady under 45 years of age and almost 50% of the ladies above 45 years, which means that almost 75% of the ladies who may get cancer cannot even go through a mammogram, right? With a good result, right? Expecting good result. Obviously, there are other tests that one do like MRI and ultrasound and so on, which are more expensive, and multiple tests need to be done to actually get to them if they actually get to those equipments. Now, with this, what happened was we said, okay, of course, there's like millions of mammograms or X-rays that are available on the open source. So that's one, like I said, it depends on the problem. We're starting off with a problem statement that I will use existing data and make more sense out of it. Then clearly there are many resources on the web, starting from Kaggle, which is more like researchers' den, I would say, like where it's all cleaned up data, like you just take and play with the models and so on, but it's not more realistic. But for individual, like for example, if you want to develop a model for chest X-rays, then you can. So like that, that's possible. But coming back to our stuff, there was no such data available. So we had to really start off with our first hospital in Udupi KMC Manipal, where we spoke to the doctors, got through formal ethics clearance to get the first thermal image of the person, right? So there are formal procedures available in healthcare to set up clinical studies or clinical research to collect the data, as long as you can prove that there is scientific merit in doing so. That is saying like what you're attempting to do and why it will change the science that's out there right now. And also you're not doing too much harm to the patient. And to evaluate that, there will be like a big ethics committee of at least 15 disciplines that come together and give a thumbs up for it. So we had to go through this formal process in multiple hospitals before we actually started giving and doing this test in public, like screening camps and so on, where we actually got much more data later. But for every problem, once you figure out this is the approach you want to do, there's always a way to start with the prototyping more, where you generally partner with the clinicians to actually get started with the data, unless you're working with existing data, which can be available on the public net.
Got it. Very interesting. How about you, Anu?
Sorry. So for us, I think there were 2-3 ways of doing it. One was that, this is my second company in genomics. So the first, we already had some databases, and so we had some of that. The second was that we also did some amount of, what we would call as the early phase, look at literature, look at a lot of information that is available, whether it was for the closest cousins in terms of Caucasians and Indian data, and create your own. So we spent about 2 years trying to build that up in the beginning. We also did some research studies, and I think that's how you get started. And then you continually keep looking at each area and you keep adding. So when we started off, we started with a smaller number of conditions. And as we've got along, we've added more. So today, I think we have quite a lot of data points on our own. Therefore, we can, I think, use our own data recursively. But in the beginning, I think one of the biggest challenges is there isn't enough Indian data available for very specific disease conditions, and therefore it can create a lot of problems until you get to a certain point where you have that data that we can. And I think there are lots of projects that are now thinking about doing that from a government side, and I'm hoping that maybe there will be something that's available for startups in not too far away in the future.
Got it. Dr. Shuchin, if some startups were to essentially come and work with Cygnus group of hospitals, what is the best way?
Just call me. Very easy to do. So, yeah, I mean, we would love to work with anybody who can offer us some insights, because, see, all of us pretty much know for sure that your gut feeling is exactly like tossing a coin, right? You may be right 50% and you will be wrong 50% of the times. But most founders and most CEOs still follow that, old fashioned thinking of that I feel this is right, we should do it. So we really need data heroes in the organization, and we really need to shift the founders and the CXOs to post heroic leadership thought process, that we should have data in front of us, we should have analytics in front of us, and we should make our decisions based only on that. And if any startup wants to come and work on it, and it will be a win-win for all of us, because they can pilot it in some of our hospitals. We run hospitals in various communities, in various geographies, so we have a lot of diversity in place, not just on the geographies and communities we work in, but also on the case mix from hospital to hospital. So we are in 5 states of North India, working mostly with semi-urban and rural communities, so the volumes are huge as well. And I think we are very amenable to anyone who wants to come and work on it and squeeze the data out and see exactly what we can decipher out of it. So that's not an issue at all. I think it's just a small WhatsApp message or a call or an email should we should be off the blocks.
That's incredible. I think um, definitely, it usually takes a lot of time, but I think folks like you are definitely going to push the pedal, make it much more easier for startups to, collaborate, work together. Um, I also wanted to touch is that what are some other opportunities that are opening, you already spoke that, right? Like there's always a chance of it, the decision being 50-50, right? So I'm assuming a very large opportunity is essentially that how do we bring better patient outcomes, right? But what are other domains, or essentially what are other possibilities that could be solved for using big data?
So, see, a lot of things I think in healthcare we generate, as I said, humongous amounts of data minute to minute from all our monitors, from all the wearables, from all the machines. But we also generate a lot of data from the softwares and the billings that we use. So, I think one important startup possibility, which I think a few people have already started exploring, and a health stack is also being built around it, is rapid, no touch claims processing for all medical claims that come in. Unfortunately, now the medical claims processing is a very tedious manual task in most organizations, especially in the public sector. You have to fill up your files and then get them signed by the referring doctor, and then the files are deposited in the claim section, where a person goes through each and every billing item, each and every drug, each and every investigation, and checks whether the claims are genuine or not. So startups, I'm sure, can build a lot of products on claim processing to weed out irrational and unethical claims. I think that will again be a win-win for both sides, because hospitals like ours and many other hospitals will get much more rapid clearances of claims, and we can then push for better rates as well, because most of the claims that are not really true will get weeded out already. So most healthcare insurance organizations which are now running into losses will really appreciate if someone can help them out there This is, I think, one of the clearest cases which can be very rapidly deployed, doesn't need any deep medical knowledge. Machine learning can be put to use very rapidly to, generate hundreds and hundreds of, claims per minute. Second, I think one of my friends has also started this, not just in healthcare, but of a much wider range to solve supply chain issues, because supply chains affect everything, right? From the air we breathe, to the food we eat, to the machines that we use. And recent COVID issues and the Suez Canal blockage, and now recently the chips shortage has exposed to us what a small supply chain issue in one sector can affect the world at very rapid pace these days. So, solving supply chain issues, exploring alternate routes, clearing port blockages, and exposing new vendors and new customers to each other, and seeing, if I am a vendor, where is my demand, which hospital is looking for my product now, which organization is using my product more, where I can get better rates. And similarly, if I am a hospital, where is my this product available, who's doing it well, who's doing it better quality, who's doing it lower rates. So these supply chain exposure softwares use a lot of data points again at all vendors and customers, and try to find out and match each other. So many cases, I think, we can, of course, medically, there are a lot of cases, but I don't want to go into complicated medical terminology here. But of course, a lot of opportunities based on big data analytics, and helping the people using it.
Understood. Geeta, Anu, how about you?
Sure. No, and I would like to sort of look at this in a more like broader, systematic way, where generalizing. I think what Dr. Bajaj mentioned is like very, very, very much on the dot. But overall, when we have data coming from different sources, the variety one that we talked about, healthcare, could be from the labs, could be from the claims, could be from the patient in the ICU, or patient generally in the general ward, and so on. We could actually divide the different, or categorize the different type of applications into possibly like four big buckets. So one which we are doing at Nirmay is more clinical in nature. That is, we are trying to use machine learning, AI, and predictive analytics to look at the patient data, whatever data is available, every data that's available about the patient, and trying to predict a future issue that may be cropping up. In our case, we're looking at breast cancer or cancer in general. This could also include genetic information, right? When we talk about all the information that that are available about the patient himself. So that the clinical decision support systems is the general category of applications for different diseases, different conditions. You can also think of it like risk assessment, right? So that which patient to prioritize, so that we actually try to stop that state, to stop the patient from going into that state, which is a more critical state than what it is today. Just that's a clinical decision support system. So that's one category. The second category is really the operational efficiency, improving the operational efficiency for the provider, the hospital, right? How do we reduce the waiting time of the patient at different divisions, different departments? How do we track when the person actually entered, when they actually filled the registration, so on and so forth? And how do we, like in this operational efficiency, how do we ensure that the beds are allocated, resources in general are allocated appropriately? How do we ensure that the people resources are scheduled right? And how do you ensure that the doctors' schedules are rightly met? How do you match the patient's requirements to doctors? So all of these sort of operational efficiency improvement techniques is another big bucket. It's all of these are as critical as and as valuable as each other, right? So this is another one. And in the operational efficiency, I think Dr. Bajaj mentioned about supply chain efficiency. So that is one one aspect of how do you make the whole hospital efficient as a service provider, service being healthcare and wellness, right? And the third bucket is really the stakeholder aspect of it. There are several other stakeholders for the hospital, like the insurance, the claims that Dr. Bajaj mentioned falls under this. It could be the pharma, which is providing the medication, right? The drug development. So all of these sort of the stakeholders with respect to the hospitals. So that's the sort of the third bucket. And the fourth bucket is actually something that is probably coming up more now is the infrastructure, the technical infrastructure. There could be like people in the audience who have ideas on, let's say, telehealth. How do I build an app to connect a doctor to the patient, or have a better way of having this teleconferencing, right? So that the doctor and patient feel more in real or real like feeling of interaction. Or it could be like a mobile app, all kinds of interactions which are technical infrastructure based. It could also be related to cybersecurity. And we have this we talk about health stack. That's also an innovation more in the technical infrastructure piece. So maybe there are more buckets, but currently I can think of these sort of 4 buckets of innovation and use cases of big data that healthcare itself, provides an opportunity for. So anyone out there who wants to sort of think about it, about their ideas in each of these buckets, and there are different constraints and different requirements for each of these buckets. For example, for clinical, you have the strict regulatory requirements of releasing any product, going through the CE mark or DCGI mark and so on. But in the infrastructure, maybe only the making sure that the privacy is mentioned. So there are a different time to market for each of these buckets, but it'll be good to think about your own ideas in the audience in which of these buckets, and so the path to market is kind of different, and the speed at which you can go.
Anu, before I come back with the same question to you, I actually wanted to ask Dr. Bajaj that what are his concerns, typically when somebody comes to you stating that, hey, we essentially want to work with you, just the way Geeta said, we went to a hospital and there were different, departments essentially, thinking about it, that whether we should go ahead or not, right? Like, what are these major concerns? It'll be very helpful for early stage entrepreneurs to understand and be well prepared before approaching a hospital or a medical institution.
See, whenever anybody comes and talks to us about analyzing the data, working on the data, so you need to show us very clearly that how do you plan to anonymize it, right? Of course, patient data is very confidential. We will need to take consents of all patients, but that can happen only in the future. We do take consent for using data anonymously for all patients anyways. But if we do not get that comfort that this data will not be used unethically, will not be sent out of the system without our consent, will not be properly anonymized, will be used to contact the patients for various purposes, if that is a concern in even 1% of the people sitting on the decision making board, then it is very difficult to get the process forwards. Because see, what I can do is, if somebody comes to me, an entrepreneur comes to me, what I can do is connect him to the right people in the hospital, right? That this is the operations team, these are the people, this is the IT team, they will help you get it done. But when the formal proposal comes in, then of course these questions will be asked, and if they are not to the satisfaction of the people working, then it is very difficult to get the proposal in action. So please be very sure and very clear of how to expose this fact that all this data will be anonymized and will not be used for any other purpose except for the one that we are giving explicit permission for.
Very helpful. Very, very helpful. Got it. Anu, sorry, sorry to skip you for a second.
No.
Jumping back, wanted to hear your thoughts. What are potential use cases that you think startups could build on?
So I think it depends on where they want to do, what they want to build, and also the intent of what problem they're trying to solve. I think Geeta has mentioned a large number of use cases already, but I would say that, let's say if I want to add a few more to that, I think one is that if you're thinking about the future and you're thinking about how we're going to have a lot of your devices interacting with the data that you're already doing, then I think putting those that data together would be an interesting aspect of putting it. So one is that if you're working with small medical device manufacturers, interfacing that with other data types, I think that would be an interesting thing to solve. The second is that if we are looking at, I think when Dr. Bajaj mentioned they can use it in anonymized format, but not otherwise. I think one thing, for instance, what we are doing is we work with an Israeli company to sort of use a blockchain-based approach to make sure that consumers have access to that. They have a little bit more control on their data. And I think when you use technology like that, then it allows you to be able to use data in a way that is ethical and yet be able to use by multiple types of stakeholders. And the third use case I can think of would be that if you're looking at it from a preventive point of view, then are there other factors that are there that we haven't thought about right now, whether it's the environment, whether it's other things. So if you can get data on that and see if that data can be integrated. So I think in the end, it will be all about, can we find the right things to integrate, because it's not just about collecting data, but collecting appropriate data, because garbage in will be garbage out. So I think Geeta mentioned veracity of the data. I think it's an important fact that when you're collecting healthcare data, then make sure that the data you get is of good quality, whether you collect it from a hospital, whether you collect it yourself, whether you collect it from the consumer. I think that has to be an important aspect of it. So there are many things, but I would say most important, make sure you have good quality of data and clear understanding of what they want to solve, because then I think you can put pieces together. Otherwise, you'll have lots of data and nowhere to go. So.
Yeah, no, very, very wonderfully put. I just wanted to, request the audience, if you have any questions, please feel free to post them in the chat box. We'd love to, take some Q&A. Also, coming back, Geeta, I just wanted to understand, what is your typical, go-to-market? Do you work with hospitals, institutions? And the same question for you, Anu, how does this work essentially?
Right. So as I mentioned, we actually do breast cancer screening. So we are a technology provider, the product provider. So we go to a hospital. We actually have two different business models. So one is we sell the whole product and solution as a managed solution, where we sell the hardware, software. We just ask for a room and set it up for them completely. So next day they can start offering, as a hospital, offering the breast cancer screening test. With training, installation, and also if they don't have a radiologist, we have a panel of radiologists who can sign the report, and so any simple diagnostic center can go for it. So this is one primary model. The second model is where people are not walking into a hospital, because that thought process of a preventive check or a proactive check, right, is still picking up. So we have this outreach model, as we call it. So where we partner with NGOs, and would love to work with Dr. Bajaj here. I've already made a note. I'm going to send you an email, right? And people who are already working with the community, right, in some form or the other, and then provide them these tools, train them to do it, or in some of the cases they want us to perform. So we have a small screening ops team, which will, our technicians will go to the camp for the non-government organization or a cancer society. Or sometimes it could be, many times it could be a corporate asking us to do the camp for their employees, women employees in the office, because our solution is completely variation-free, portable, all of the good stuff, and also privacy aware. Nobody sees or touches the person during the test. So it can be done in the office, in the same conference room, just putting like curtains and doors around, right? So that which is like a per day basis, like a camp mode, is also something that we do. And in terms of going to these target segments, of course, we partner with insurance and pharma vendors to reach the right kind of audience. So that's sort of typically how we go to market.
Interesting. Great. Great to learn that.
So we basically, we work with hospitals in two levels. One is to partner with them on specific disease-based cases. So if they have, for instance, a problem on a cancer-based thing. So we do an NGS panel for that. So I think that would be more specific to a specific problem that an individual has, right? So then you would run the whether an exome sequencing or one of our low-cost cancer panels or something like that. So that would be the part that you do, which is more patient to patient, indifferent on the patient to patient. The second is where we partner with them on the health check basis, where we can put together what they are doing along with what we are doing, and that would be more like one product that fits. I mean, the product is, for instance, Genome Patri. That Genome Patri can then be sold to a whole bunch of people who are looking for putting that piece together. And of course, I think we work with other channel partners, whether we are at the airport, we are also at certain hospitals, we have certain other channel partners and so on. So a lot of online channel partners, a lot of offline, some distributors and so on. So that's typically how we would go to. But most easily, I think, is people come to our website, order a test, or they go to Amazon and they order a test. So I think it's a relatively easy way of getting people to come to us.
Wonderful, wonderful, and especially with respect to both of you, how do you, while Geeta said there's curtains to take care of privacy, but what about data privacy? I mean, what are certain extreme measures you have to, kind of take, and how do you take care of, of that?
Okay, so absolutely, data privacy and the privacy of the person, both though different, are very, very critical, both of them, right? So first and foremost thing is, especially when we do B2C, which is like a camp, or also coming to our website and book an appointment for home screening and things like that. So there's always a consent element to it, right? There is a user consent form, which is informed consent, we call it. Like basically, you have to tell them what's happening. And then so they have the consent to share their data to allow us to actually capture the data and then use it for analysis to generate their own report. Having said that, the anonymized version of this can still be used for possibly improving the product and doing some additional enhancements to the product, which is this anonymization is very, very important. Even when we collect the data, we kind of, delink the patient details with the anonymized ID, like a patient ID mapped to the name and mail ID separately. That mapping is required because you have to send the report back to them. So we need that personal data, but that personal data is encrypted and stored and transferred also encrypted. So we follow the GDPR guidelines, though because India, it's not necessarily required. We're also regulatory cleared for Europe, so we have to follow all the GDPR regulations. So that's sort of one part. So every time we capture a personal data for communicating the report to them, patient's report to them, we say store it in an encrypted form, and only non-anonymized data is actually sort of used for any other further pipeline. And also, like the GDPR regulation says, you have to give them a facility to say, any patient can come in and say, delete my data from your database at any point in time, right? That sort of, is also a requirement to do that. So I think these are the 2-3 important elements that one need to see. And then finally, we have to publish our privacy policy on the website, right? For anyone to know, like if there is any concern, whom should I contact, right? So the name of the, what do they call it? So basically, they have some name, basically the data, okay, whatever. So we need to, the person's name and email ID is given there, and they need to, they can contact them for any privacy issues. Essentially, it's the data privacy officer whose name will be given. So Anu, do you do differently or?
No, pretty much the same. So I think first is when you're given a kit, you are given 3 consents. Actually, you sign along with that. One is to let people know that they're doing a genetic test. Second is they want to help anonymized data be part of the database or not. And the third, of course, is also saying that there's certain other parameters, whether if they're for minors, it's different and so on. So all these things are done in a consent format, which we do in the beginning. The second part is to separate out the personal detail from the actual data, right? And that is done using our we have a limb system that does basically that separation. There's a separation in terms of rules and who gets access to what. And it gets double anonymized in the part of the process of when it comes to our lab to when it gets done. What we have added on top of that is the blockchain, because that allows the user the ability to be able to then say, can I decide who to share with, and if they want to sell their data, they can do that as well. The reason why, I think someone mentioned this on the chat box, and the way we are doing this is because we're putting these pieces together. We also have other partners that are selling it. So in which case, we don't have access to any of the data, whether it's the address or other things that are there. And that's why it is completely anonymized. So I think we do understand that genetic data is extremely important, and people are rightfully worried about the privacy of that data. But I think it is also the data that has actually helped us understand a lot of cures and a lot of coming up of new drugs. So I think there needs to be a differentiation of what people see as value of the data that is there for the greater good versus the invasion of their privacy for sacrificing their whether employability or whether it is understanding of other things. So I think, and we also, like Geeta mentioned, we all have to publish a privacy policy on our website. And I think that's common for pretty much everybody as well.
That's true. That's very interesting, and really, really cool to learn that, by the way. Last question I have, because Harsiddhi is here, that means we need to stop. The audience, again, if you have any more questions, please feel free to write it in the chat section. We're right here to answer your questions. I have a feeling Geeta already said, hey, Dr. Bajaj, I would love to, play it, right? And I'm literally, since then I've been thinking, right? There would be maybe some signal hidden in the genome patri, which could tell me that, Mrs. X is, probably has a higher chance of maybe having a breast cancer or not, right? I'm just wondering what kind of collaborations are possible between different kind of, big data analytics, big data companies, essentially. Just curious to hear what all could be cooked here.
Yeah. For breast cancer, I think discussing, we haven't been able to fully get it to action, but there are certain genes which are known to be high risk for women with mutations of BRCA1 and BRCA2 and a couple of others which are coming up. So if Anu can identify people who have those genes, and they can actually take our test every 6 months, because high risk means it actually progresses from stage 1 to stage 4 very, very quickly, right? And so that's sort of one pipeline thing. And also similarly, if you find somebody who has cancer, their family members can be, sent for a genomic test so that, they know whether it's actually running in their genes, right? But it's not like every person who has it has a BRCA mutation will get cancer, but just they can be more careful. And definitely Dr. Bajaj will try to sort of collaborate, and try to make this available for millions of people whom he's already helping. So that's from my side, and I'm sure, Anu and Dr. Bajaj may have.
Yeah, I think at the end of the day, I think somebody like Dr. Bajaj owns the patient that walks into their premises. So that the patient can easily get tests like what Geeta and I'm doing. And I think ultimately it improves the value of what you can provide to the final customer. So yes, we have our own channels of doing it, but I think when it comes to working with the hospital and doing it, I think it makes it all the more powerful, because I think what Geeta is telling you is where we are today, and the genes will help you understand if there's something hidden inside that we don't know yet. So I think putting those pieces is always going to be a great way of actually collaborating and getting things done.
Dr. Bajaj, any final comments?
Yes, I absolutely agree with Geeta and Anu, because of it's not just working with the patients on getting them more tests done and getting the analytics done. I think it is actually working to decrease the cost of the disease massively. So if we can do the preventive part of it, we don't really need to invest 100x of that in sick care 10 years down the line, right? So a stitch in time saves 9, right? So if we can pinpoint that this person will have breast cancer 10 years down the line, or this person will land into kidney failure, this person will have a diabetic foot which will need an amputation. I mean, then we can actually just spend 50 rupees for the treatment instead of spending 50,000 rupees later. So this is very, very important, and I hope that not just collaboration between us, but we will have some advocacy efforts also going in, and the governments will also realize the value of this in the preventive part of the healthcare.
An absolute last question, Anu, Geeta, are both of your tests covered in insurance? If not, are we seeing that any soon?
$1 million question. It's not yet covered. Having said that, we are working with insurance vendors to figure out how to make that happen.
So I think some parts are covered, some things are covered, and in some specific corporate, some tests are covered. So it's still not yet not something that is widely available. So I think we need a lot more advocacy to get to where we want, because ultimately I think if insurance covers it, I think then we can get a larger number of people doing these tests, and as a result save lots of money for whether it's corporates, whether it's the insurance, whether it's the individuals. But I think that thought process hasn't come into being, because unless you have a large amount of volume of people who do that, I think neither the insurance companies will see the value. So it's like a chicken and egg situation. In the US, I think the reason why the breast cancer especially came down from where it was to like 90% of where it was not long ago, was primarily because they were allowed to do BRCA tests, they were allowed to do a lot of tests, and they were all covered in insurance. So even though they were a few $1,000s, I think consumers went ahead and did it. And I think that's the challenge. I think though what we are trying to do is to bring down the cost so rapidly that hopefully it is not even necessary to get to an insurance by the time. But it would be very nice to have insurance cover it.
Sure. I mean, there's so many new age insurance tech startups happening. I'm definitely seeing this getting solved much faster than we are imagining. I've already said my last question twice, although I'm really tempted to ask another one, but I think we're running out of time. So Harsiddhi, over to you. Thank you so much.
Rahul, I'll give you one last question, one more.
Yeah, this is like my last lifeline. Anu, Geeta, is the footprint of both of your companies only in India at the moment, or you're literally building global companies where because this is predominantly tech, right? And please correct me if I'm wrong, which could essentially be exported as well. So just curious to learn about that.
Right. So breast cancer is a global issue, and the gap that we talked about is a global gap today. So definitely we are making the innovation made in India go global. We're already started off in Africa and just getting started in Europe as well, and Philippines. Yeah.
Sweet.
So we do get samples from other countries, but that is not yet a very sustained effort. I think some we have very clear distributors in some countries, but it is we are planning to set up operations in some overseas location shortly.
Got it. Awesome. Thank you so very much again. This was fantastic, learning so many new things. Thank you so very much.
Thank you. It was a pleasure meeting all of you as well. Thank you.
Bye.
Thank you, Anu, Rahul, Suchin. Thank you, Dr. Geeta. Thank you so much for your expert insights. And from this entire discussion, I have so many questions coming up when we talk about going global, the acceptance of going global, the challenges of going global, because India was one of the developing countries up till now, and suddenly the graph is turning around. So I wish that we could do this once again some other time and continue the second part of the conversation with all of you. And I'm grateful for all of you for taking your time out and sharing your insights with all the participants today. Before you guys leave this webinar, we finish this webinar, I again would like to reiterate that please make sure you visit the website and register or apply for the challenge, Aarogyam challenge. It can be a great help to all the new startups, healthcare startups who are coming with new innovative ideas. We might look at all the panelists today in future being a mentor with us for this challenge also. We hope that happens, and I am going to share a link in the chat box for the feedback for today's panel discussion. I request all the participants to fill it. I thank all the participants again and all the mentors and experts for today, and it was great having you here. From on behalf of AICGUSEC, and I would also like to thank Thai Delhi for supporting us and making this happen. Thank you, Nitin from Thai, for helping us out. Thank you, everyone, for being here.
Thank you. Excellent moderation.
Thank you,
Thank
Rahul,
you.
for such
Bye.
wonderful
See you
moderation.
guys.
Thank you.
Bye. I request all the participants to please fill the feedback form. It's shared in the chat box. Once you do that, only then leave. Thank you so much.